than physiological criteria. And in all cases, we want to know how. And of course, mapping is not monitoring. Monitoring, the gold standard for corticospinal tract monitoring for years, of course, has been transcranial motor evoked potentials. There are still controversies about the appropriate criteria. I'm not going to go over those now. I will point you to the January 2017 issue of Journal of Clinical Neurophysiology, which is guest edited by David MacDonald, and it's an entire journal devoted to the question of criteria for interpretation of changes in transcranial motor evoked potentials. TCMEP obviously has its issues. It's very sensitive to anesthesia, where you need close cooperation. We won't go over that. Obviously produces a significant movement, which may limit how often you can actually elicit a TCMEP. And the site of the activation is deep to the cortex, so superficial damage may be missed by the transcranial technique, which activates several centimeters deep. We're also then going to talk about direct cortical motor evoked potentials, where we're stimulating with a strip electrode or perhaps a ball tip probe directly on the cortical surface. We'll go over the issues of bipolar or monopolar stimulation. But the advantage of the direct cortical stimulation is we have less movement, essentially none that disturbs the surgeon. Therefore, it's amenable to continuous monitoring rather than, excuse me, sir, can I run an MEP now? Which is often the case with transcranial, because the site of the activation is at the surface. All right. We need to understand the anatomy, so we're going to spend a few slides just reviewing the details of the anatomy of the corticospinal tract, which, as you all know, originates in the precentral gyrus, Brodmann's area 4. Interestingly, phylogenetically, it actually originally was a pathway from the sensory cortex and projected to the dorsal horn in the spinal cord rather than the ventral horn that we normally associate with motor tracts. And in fact, 1/3 of the corticospinal tract is still post-central and projecting to dorsal horn, possibly as a means of preventing too much of a sensory response to movements that we initiate ourselves. As you know, the homunculus is functionally organized about 1/3 face, 1/3 hand, and 1/3 the rest of the body, roughly. At the microscopic level, there are actually multiple maps, but those are beyond the scope of this talk, certainly. Corticospinal tract is axons of the pyramidal cells in layer 5 of the motor cortex. And these are primarily myelinated fibers, and so they're rapidly conducting. And the fastest 1 or 2% of those are dominating the response when we trigger a motor evoked potential. However, it's not the same 1 to 2% when you trigger it again. So you're always getting a different population, and therefore we have a very variable motor evoked potential as opposed to the stereotype pattern that we see with sensory evoked potentials. Now, notice that the fibers from the different areas of the cortex are very spread out at the homunculus, but then they must come together into a pretty tight bundle here in the internal capsule, which is our next slide. You see that the internal capsule has this kind of L-shaped with the genu or the knee bend at the face area, and then the mapping that we saw at the cortical level is preserved here in the subcortical level, face, arm, trunk, leg, as you see as we move from anterior to posterior. And this is a general feature of maps in the nervous system in general, that will have a map at one level and then it projects to another level, and those projections maintain a somatotopic organization or a visual topic organization in the visual system as they go from one part of the nervous system to the other. There are, of course, other kinds of motor fibers mixed in with the corticospinal tract, but they don't contribute to the motor evoked potentials that we record, so we can safely ignore them. Moving on downstream, we see in the middle of the top, we see the level of the cerebral peduncles, and the somatotopic organization is still preserved there. The bottom slide right, which we're going to see later on in this presentation. But again, you see that base, arm, trunk, and leg somatotopic organization is still preserved. So this is the normal anatomy that is expected. If you look on the left of that photo on the right side there, you see that there's a cavernous malformation that is distorting the expected anatomy. And again, that's one of the key points, is that you need to know what to expect in the normal anatomy and then find out how is that different, because that's going to be crucial for a guiding surgeon to a safe resection. So these fibers continue on downstream. They cross in the medulla. At least most of them cross, and that's 70 to 90%, and continue on down into the spinal cord as the lateral corticospinal tract. A smaller percentage of them don't cross, except when they finally terminate in the spinal cord, but those only go to the cervical or upper thoracic level. It's not clear whether they contribute to the motor evoked potentials or not. I love this slide. I just toss this in to show the wonderful things that can be done with modern imaging technology. This is diffusion tensor imaging, DTI, of the decussation of the pyramids. And the details are there, as you can see. But these kinds of images can be obtained from virtually any cortical region of interest. You can say, I want to see where the fibers go from here, and you can then get a nice visualization of the geometry and the organization and the mapping, if you will, of the white matter patterns. You've seen some of these beautiful images of where they take away everything except the tract. You show the tractography, and it's quite impressive. Moving on down to the spinal cord, the anterolateral corticospinal tract is the one that we're primarily concerned with. And it, again, has a topographical organization where the cervical projections are more medial and the sacral projections more lateral. And so as you go down, projections peel off from the medial part of the corticospinal tract, leaving the more lateral ones to travel further down. So it's, again, a nice topography. And the direct terminations are primarily on the lateral portion of the anterior horns. It's most of the axons actually terminate on interneurons. So again, relatively few direct upper motor neuron to lower motor neuron synapses. And since they are concentrated in the lateral portion of the anterior horn, the motor part of the spinal cord, that happens to be where the distal muscles are most represented. And so this is the reason that we get the largest MEPs from the smallest muscles. The intrinsic muscles of the hand and foot and face are the ones that have the densest innervation from the corticospinal tract, the finest movements that can be produced there. And those are the ones that are primarily activated with electrical activation of the corticospinal tract via transcranial or from direct cortical stimulation. Therefore, you get big evoked potentials from the hand and pretty small ones from, say, the deltoid or the trapezius or biceps. And there is a tendency to favor flexors over extensors. So again, all these details are relevant because they're going to be different when you get down into any of these areas with a tumor compressing it. So you need to know what to expect so that you can gauge the differences in this particular patient from what you expect. And again, that is the feedback that the surgeon needs to know, can I keep going or do I need to slow down? Because here is something that isn't where it normally would be. So, with that said about repeating the reference paper for the MEP change criteria, that is David B. MacDonald in 2009. I don't have the exact reference with me right at my fingertips, but if you search, do a Medline search for D.B. MacDonald, MacDonald, you'll find that he's written most of the diagram from one of my mentors, the late great John Desmet, Belgian neurologist, who was one of the people who figured out a lot of what we know about the generators of somatosensory evoked potentials. So what we're looking at on the right is a section, or an axial section through the somatosensory cortex at the level of the central sulcus, with posterior to the right, anterior to the left. And we know that the earliest cortical response that we can record to upper extremity stimulation is generated by pyramidal cells in the posterior central sulcus, and they're oriented parallel to the cortical surface. And so that's that little arrow that you see that's marked N20. And at the time of that earliest response, that dipole is negative posteriorly and positive anteriorly. That polarity reversal is transmitted, of course, at the cortical surface, but also even at the scalp. So if you imagine either at the scalp or at the cortical surface, if you move an electrode along from posterior to anterior, you'll first see the negativity that's there posterior, and then as you move forward, you'll reach a point roughly where the slide says Rolando Fisher there, that is about halfway between, and the electrode will see both the negative and the positive in that dipole, which will cancel one another out, and so you'll get no recording at all, even though you are at that point as close as possible to be to the actual generator itself. Then as you move on further forward, now you see the positivity. So by recording from a series of electrodes, either on the scalp or on the surface of the cortex, ranging from negative to positive, from posterior to anterior, you see the shift from negative to positive with an area in between where it actually becomes no recording at all. But what's interesting is you see that there's a second generator here labeled P22 that is also activated from the sensory part of the thalamus, BPL pars oris rather than pars caudale. Notice that two things about it. One is that it's slightly different latency, 22 milliseconds rather than 20 in a normal-sized person with normal conduction velocity. And the second thing is that it's oriented so the positive end of the dipole is pointing up towards the surface, and the negative end is pointing down. Now, if we do our thought experiment again, and imagine moving an electrode along from negative to positive, looking at just that P22, we would never, I'm sorry, I keep saying negative to positive, I mean posterior to anterior, we would never see the negativity here. We would see greater and greater positivity until we got the maximum positivity about where the word says pre-Rolandic there, right over P22. And then as we move further anterior, that positivity would fade, but we would never see the negativity of that dipole unless we stuck an electrode deep into the cortex, which of course we're not going to do. Now, what happens when both of these are activated slightly out of sequence? You see a spatiotemporal summation of both of these active sites, and that looks like this. So here now we're recording from a strip electrode with 4 contacts that's been placed across the central sulcus, so that contact 1 is actually posterior to the central sulcus, and contacts 2, 3, and 4 are anterior to it. So if you look at the latencies here, you see negative being up. You see at the very top trace there, N20.2, which is the negativity of the dipole in the somatosensory cortex. Now, as we move forward, we see, yes, what looks like a polarity reversal, but if you look carefully at trace 2, you see that it's not P20.2, but it's rather it's like 21.5. This is the contribution of that later dipole that is actually in the motor cortex itself, but giving a sensory response. And then as you move to contacts 3 and 4, you get further away from that second dipole, so you're more seeing a negativity that's positivity. I mean, it's moving back towards a similar latency of the negativity that was seen posteriorly. So recognizing this difference in polarity and latency is the key. When you see what looks like a polarity reversal, but whoops, the positivity is a little bit longer latency than the negativity, bingo, that electrode is right over the motor cortex. Incidentally, it's always good to have a scalp SEP along with this. It's not shown in this slide, but you want to know where N20 is. You want to make sure, because these are nice, clean recordings. They're sometimes not this clean. You've got multiple peaks, and you want to make sure you know which one is N20. Obviously, depending upon the craniotomy, you may not be able to put your electrodes in the standardized positions that you would like. The important thing is that one electrode is behind the central sulcus and one electrode is in front of the central sulcus, so that one's in the negative field, one's in the positive field, so you'll have the maximum difference between the two in your differential amplifier to give you the largest signal. Okay, let's just look and see, are there no more questions at this point? So, having identified the central sulcus with this polarity reversal, you now know where the precentral gyrus is, where the motor cortex is, and so you can stimulate it and get a response. This is a very old technique. It goes back about 80 years now. Penfield and Baldry, working up in Montreal, pioneered this method. They used a transformer connected to the electrical outlet in the wall, and so it was stepped down to a safe value and applied it right to the surface of the brain with a sterile probe. Nowadays, of course, we're much more sophisticated. We do it all with digital circuitry, and we have a thing called the Ogeman cortical stimulator, which emulates what comes out of the wall. 50 or 60 hertz, and typically we stimulate with a few milliamperes, 1 millisecond long pulses, and at 50 hertz for 1 to 2 seconds. Penfield and Baldry just looked to see what moved. We've shown almost 20 years ago that it's much more sensitive to record EMG, and that's what you see here on the right. Above A, B, C, and D, you're showing the time of the stimulation. In A, you see at one site a very slight response in trace 4 there, which is the forearm. Trace 5 would be the hand. In B, the surgeon is using the same level of stimulation, has moved the electrode very slightly, and now we get what is a very clear response from the forearm muscles. Turning the stimulus up to 5 milliamps, we see a much larger response. And finally, at over 6 milliamperes at the same site, now the response is so large that it's off the screen, and the anesthesiologist finally says, oh, he's moving his arm. So at the lower stimulation intensities, it was very clear that we had a good motor response, but there was no movement. So much lower level of stimulation if you record EMG as opposed to looking for movement. So you can record, obviously, EMG from one end of the body to the other, and it's very easy to see where the response is coming from, whereas observing the patient, whether you look at the feet, you look at the hands, if you don't know, you might miss something. The problem with these prolonged trains is that they can elicit seizures. You know, in our first series, there were 24% of the cases we had seizures, not necessarily dangerous ones, but you can see here at the bottom, which is the foot channel, the stimulation ends right at the beginning of the set of traces, but the foot muscles keep going, it's tapering off, but the surgeon is alerted, squirts some cold ringers on the cortex to terminate these. The seizures can be more dramatic than this. Spread to many channels may involve gross movement. So that's obviously a drawback of this technique. It doesn't seem to work as well in the pediatric population. And finally, it's a mapping technique, but not a monitoring technique. The surgeon is mapping, says here, 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 yes, no, and then puts the probe aside and does whatever she does to remove the tumor. It would be nice to have a method that did both. So here's the better solution, is to potentials where we use a brief pulse train of high-frequency pulses, just like we do with transcranial motor evoked potential, but obviously at a lower intensity since we're stimulating directly on the cortical surface. We originally did this with the transcranial stimulator, which was a little scary since it could go up to 1,000 volts. We had to keep it below 100 volts. 100 volts still seems like an awful lot of voltage to be delivering to the cortex, but actually if you do the math, since it's a 50 microsecond long pulse, that's 1/20th as long as the 1 millisecond pulse is the Ojemon method uses. And so you actually have to divide the total charge delivered by 20, and so 100 volts comes down to being equivalent to about 5 volts, a few milliamperes. So it's actually about the same amount of current that's being delivered per charge, and of course far fewer charges, far fewer pulses, because we only have 5 or 6 pulses rather than a train of 60 hertz delivered for 1 or 2 seconds, which could be as many as 120 pulses. And then, of course, again, just like a transcranial motor evoked potential, we just record time-locked responses and see this nice evoked response here, specific from the hand area. You can do this either with a strip electrode, as shown in the photograph, or you can actually map the cortex with a handheld electrode with a low-tip probe. The nice thing about this is that it does not appear to generate seizures as long as you keep the train repetition rate low. The first paper, Campos et al. In 2000 had 0 seizures in their series of 70 cases, compared to that to 24% in our paper using the Ojemon continuous stimulation. And of course, the advantage is that once you have located the central sulcus and are using this technique, you can lay this electrode down over the motor cortex. The surgeon's obviously not going to go through the motor cortex, so that electrode can just stay there during the entire procedure. And now you can periodically trigger a direct cortical motor evoked potential, and now you're using the same electrode that you mapped with now for continuous monitoring during the entire time of tumor resection. Again, just to compare the direct cortical versus the transcortical, this is a slide from a publication of Andreas Schellenje from Germany. You see the transcranial stimulation here in blue goes pretty deep into the brain, whereas the direct cortical stimulation is pretty superficial. Therefore, it's more focal. You require a much lower intensity. The transcranial stimulation obviously requires that high voltage stimulator because the scalp conducts 90% of the electricity compared to the skull. And so most of the current goes through the scalp. A little of it gets through the skull, and then you've got a layer of CSF that also conducts very well. So a lot of the current goes through the CSF. So, only a very small percentage of the current that you're delivering through the electrodes from your high voltage stimulator actually gets to the brain. So these 2 slides are in the handout, and so I don't want to spend a lot of time with them because I see that I've already used up half of my time and I'm not halfway through my slides. So you're all, you do transcranial MEPs, you're familiar with the discussion you need to have with your anesthesiologist about TIVA. The stimulation now can be done with a standard stimulator. Cadwell ES9 will allow you to deliver trains of pulses at longer pulse widths, like half a millisecond, and use sort of typical pulse trains, 5 pulses at 2, 3, or 4 milliseconds ISI, up to as much as 20 milliamps. Usually you need less than that if your electrode's in the right place. You can stimulate either through the subdural strip or a ball tip. Ball tip is maybe better for mapping. The subdural strip is better for continuous monitoring. A return electrode somewhere else. An important point is when you're stimulating the surface of the cortex, the anode is the effective electrode, and when you're stimulating subcortically, the cathode is the effective electrode. Stimulate too frequently. If you're stimulating at 1 per second or 1 every couple of seconds, you're not going to elicit seizures. We've tried going up to a train 3 times per second, so from and we can elicit some seizures with that. So we try to keep the rate of the repeating pulse trains down to 1 per second or less, which means that the surgeon may have to go a little more slower than she would prefer to do, but most surgeons can be trained that they would prefer to avoid the seizures. Subcortically, this doesn't seem to be a problem. You can go a little bit faster because it does not seem to elicit seizures. And then you record from a whole set of muscles on the contralateral side. We already talked about locating the motor cortex by locating the central sulcus, rotate that 90 degrees, and find the motor gyrus, motor cortex, and put the electrode so it's over the motor cortex. And then by trying different contacts, one thing's pretty interesting is that you can actually find the mapping of the motor cortex, and in ideal situation, you can have one electrode that is over the hand area and another area, the electrode that is over, say, leg or approaching towards foot area, and with a biphasic pulse that goes first one direction and then the other, you can get responses from both upper and lower extremities, which is a pretty neat thing, and that gives you somewhat more confidence that you're monitoring more of the corticospinal tract than, say, just the hand area. So you can leave this in place, and typically we do this, we would trigger it at the lowest possible rate, which is 1 every 2 seconds. That's fast enough. Every 2 seconds, you're getting a motor evoked potential while the surgeon is resecting the tumor, and this gives you great confidence that things are still intact. It's much better than transcranial motor evoked potentials, where, of course, you have to be concerned about movement. Excuse me, ma'am, can I run an MEP right now? Okay, and then if they say no, just a minute, and then it's sometimes it's quite a while between opportunities to do a transcranial MEP because of the movement, and so you might miss something. This way, you're stimulating almost continuously. Here's again another slide from Andrea Shalania, just showing that with this direct cortical stimulation, you can see the topography of the homunculus at the cortical surface. Okay, advantages of this, of course, you can do it under general anesthesia rather than awake like Penfield usually did it. You get immediate feedback from EMG, so you don't need to stimulate at a level that produces movement. You can monitor during resection of the tumor. You're not delivering nearly as much electricity. You don't have concerns about seizures, and therefore recording the electrocardiogram for after discharge is really no longer needed. The Penfield stimulation and awake craniotomy techniques are now really only needed if you're doing the language cortex localization, language mapping. Maybe someday we'll be able to do that with brief trains, but that's not yet ready for prime time. So we're going to leave the cortex now and move down to the internal capsule and brainstem. With these big cortical tumors like we saw in the very first slide, obviously as you get down deep in there, you're now away from the cortex itself, but impinging potentially on the corticospinal tract. And historically, Ojibwan, Mitch Berger, my former chairman, that are used to use the same kind of bipolar stimulation with the long trains, like the Penfield-Boldre method. But the question is, when you're using a bipolar probe, the two contacts are a sonometer apart. Well, which contact was the contact that elicited the response? The monopolar stimulation is more precise. And now what I'm going to show you is the fact that now we can tell how far we are from the corticospinal tract by looking at the threshold. So what we're going to do is we're going to use these brief trains with time-locked EMG, just like we did with the direct cortical MEP, using monopolar stimulation. And now the question is, what criteria should we use? Yamamoto from Japan first proposed back in 2006 at one of Vedran Delides' meetings that were the precursor to the ISIN, that the closer you got to the corticospinal tract, the thresholds should go down. And he suggested maybe it was even something like 1 milliampere per millimeter. Well, the next year he came back to the same meeting and said, well, maybe what we need to do is stimulate at a constant intensity, and then the closer we get, the larger the response we get. Well, who was right, Yamamoto or Yamamoto? Surely more research was needed, and it's been done. So let me take a quick look here. Is motor mapping negatively affected by burst suppression? I am aware that protocol can be used to induce burst suppression. I'm not 100% sure of the answer, but I think that the answer is probably no. In motor mapping, we're, for the most part, not involving the cortex. We're stimulating corticospinal tract, so we're looking at descending tracts. The issue may be at the level of the synapse from the upper motor neuron to the lower motor neuron in the anterior horn of the spinal cord. So the threshold may go up. But in general, burst suppression is pretty consistent with most of these kinds of monitoring. I think in my experience, I like to see burst suppression that is more burst than suppression, a little bit of suppression and then a lot of burst. So where you're just on that edge and don't go any deeper, and that usually works beautifully. The patient's not going to wake up, but it's very consistent with all of the good monitoring techniques that you want to use. Okay, so back to the question of how can we tell how close we are to the corticospinal tract? So we're going to look at data from several countries. This one, Journal of Neurosurgery, 2009 from Japan. The problem that all of us face is how do you know exactly where the corticospinal tracts are, particularly once you've started removing tumor. You may have a beautiful preoperative scan with the DTI imaging that shows you exactly where the corticospinal tract is, and now you take tumor out and things start to shift. So how do you evaluate where they really are? Several different techniques have been used, and I'll go over these kind of quickly because I want to get to the punchline. What this Japanese group did was to measure the distance on postoperative scans. So they